Good morning, everyone. So joining again through the webinar and the teleconference, I'm doing a quick check to see if those joining by webinar are able to hear and see us. Wonderful. That's great to hear that everyone is able to join us without much audio or visual difficulties. So again, welcome to the last of our implementation series webinars on the community of practice for this year. The focus of this presentation today is going to be implementing tobacco cessation programming in cancer care settings. And we have two great faculty with us today, Dr. Bill Evans and Rebecca Truscott. As a reminder, I'm sure you are all familiar with this, but if you are interested in obtaining a letter of completion for this Community of Practice webinar, we ask that you complete the 3 requirements listed on the screen. Our webinars are being live tweeted, so if you are an active tweeter, definitely go ahead and follow us on Twitter and use the #TeachWebinar hashtag. I'm going to begin by introducing our presenters. We have Dr. Bill Evans, and he's a medical oncologist and healthcare administrator with a long career history in lung cancer. Dr. Evans has worked as a president of Javinsky Hospital and Cancer Center at Hamilton Health Sciences, and right now he chairs the Cancer Care Ontario Smoking Cessation Advisory Committee and is the clinical lead for CCO's new systemic therapy funding model. Rebecca joins us as well today, and Rebecca is a manager of prevention policy and stakeholder engagement with the Prevention and Cancer Control at CCO. And for the past 2 years, Rebecca has led Cancer Care Ontario's Smoking Cessation Initiative in the regional cancer programs. These are the disclosures of our presenters. And as a reminder, the TEACH curriculum and any slides were developed and compiled with funding from the Government of Ontario, specifically the Ministry of Health and Long-Term Care. The content of the slides are primarily based on evidence-based guidelines seen below. As a disclaimer, these materials, and as well as any of the verbal presentations or any of the chat discussions that happened during this webinar, are really only set out as general principles and approaches to assessment and treatment pertaining to tobacco cessation interventions. They do not constitute clinical or other advice to a particular situation and do not replace the need for individualized clinical assessment and treatment plans. At this point, I'm going to hand it over to our first portion of the webinar, where we will have Dr. Evans speak to us.
Thank you and good afternoon, and welcome to this session on implementing tobacco cessation programming in cancer care settings. You see the learning objectives for today's session, and particularly the focus will be on the health benefits of tobacco cessation following a diagnosis of cancer. And we'll go through some of the data that supports significant health benefits to the cancer patient, something that has not well recognized by those of us who work in the care delivery system, certainly in the province of Ontario, and I'm sure this is true elsewhere. We're going to describe the tobacco cessation initiative that we've launched in Ontario through Cancer Care Ontario's regional cancer programs. And we hope for those of you who are primary care providers that we will also impress you that it's important to get your cancer patients to quit smoking, because of the benefits that you will see demonstrated during the course of this presentation. And finally, we'll share some of the successes that we've had and the challenges we continue to face in implementing a program of this nature. Now, I'm going to quickly review several slides which I hope are familiar to most of you being interested in tobacco control. Before we get to the meat of this presentation, first of all, tobacco, surprisingly, is a legal product that kills up to half of its users. It's astounding that this product is out there and people use it and is responsible for at least 5 million deaths directly from its use. And secondhand smoke contributes an estimated 600,000 additional deaths. And this annual death toll will continue to rise to more than 8 million people by 2030 unless we, as people engaged in tobacco cessation, convince governments and patients and others to give up on smoking. In Ontario, it's a huge economic cost. Some of it's direct healthcare costs, close to $2 billion of costs treating people with various smoking-related diseases. But there's also the loss of productivity, the real human cost, estimated at almost $6 billion. And when you average that out for the population of Ontario, which is about 3.6 million, it works out to about $500 per person for direct healthcare costs related to smoking. Now, in Canada, there's been a lot of efforts by a lot of organizations and a lot of good public policy to drive down smoking rates from what they were in the 1950s, but it still sits at around 18%. And in the province of Ontario, it's a little higher, estimated around almost 21%, with 2.1 million adults 20 years and older being either daily smokers or occasional smokers. And smoking remains the leading cause of premature death in our country. And it's estimated that about 20% of all deaths over the past decade have been directly related to smoking. Now, tobacco is derived from a plant, but in the process of its manufacture and then burning it, a number of toxic substances are released, and there are at least 70 cancer-causing agents, and some of them are listed on this slide, include things like arsenic, various metals, nitrosamines, aromatic, polyaromatic hydrocarbons, and many other substances that are harmful. And the tobacco smoke in the United States has been attributed to a large number of deaths, over 400,000, of which the greatest percentage are related to lung cancer, 29%, but closely followed by coronary heart disease and chronic lung disease. Interestingly, also, there are other cancers, estimated about 8% of deaths, that have been attributable to cigarette smoking, and I'll speak more about that because it's a little less known. I'm sorry, I just diminished the size of the slide, and we'll just fix that. Little technical assistance being sought here.
That's weird. Why is it not?
You can just go to the next slide, though, and I can. Thank you. So this slide doesn't seem to have all the data that I would like to have on it. So it was a slide that showed that the smoking prevalence varied by regional health network in Ontario. And some of our regions have low rates of smoking. And you see on this slide what we call central area, which is sort of the Toronto area. But in the north, northeast, and west, we have much higher smoking rates. And you can see the very tight correlation between smoking prevalence and incidence of lung cancer. And lung cancer, at least 80% of it is related directly to cigarette smoking. There are various occupational exposures that can cause lung cancer, but the largest percentage are smoking related. 30% of all cancer deaths are thought to be related to cigarette smoking. And what may not be well known to some on this teleconference would be the fact that there are over a dozen different cancers that have been scientifically linked to tobacco use. Some are fairly understandable as the smoke passes through the mouth, the nose, and sinus, pharynx, and larynx, giving rise to cancers in those structures, or particulate material being swallowed and affecting the gastroesophageal tract and producing esophageal cancer, stomach cancer. Perhaps less understood or readily recognized is the fact that smoking's been linked to pancreas cancer, cervix cancer, kidney, bladder, bowel, and recently acute myelogenous leukemia. So in Ontario, at least 25% of all patients coming to the cancer center are either current or recent smokers, defined as individuals who have perhaps stopped smoking in the previous 6 months. And the attitude most commonly in the recent past has been that we'll just leave them to continue smoking. It's one of their few pleasures. now that they've received a diagnosis of cancer. And it's a common belief of oncologists still that people who are smoking and have cancer are not likely to give up smoking and quit. And in fact, this is not accurate. It's not what the data in the literature shows. And what we need is a heightened awareness about the actual health benefits of smoking cessation. And a lot of this information has really been assimilated quite recently through reports of the American Association for Cancer Research in 2013, a publication in Cancer Research. The Institute of Medicine came out with a report in 2014, and importantly, there's a really excellent summary of the health benefits to cancer patients in the January U.S. Surgeon General's report in 2014. So it's a lack of awareness of this information that has resulted in oncologists not being very active in trying to get their patients to stop smoking, and perhaps also primary care physicians are not reinforcing that kind of message. An additional issue we have to overcome in implementing a program in a cancer center is that most healthcare providers are not trained in smoking cessation, in the use of pharmacotherapy or how to counsel patients. And cancer centers are very busy places where if they don't know what they're doing, they're not going to raise the issue with their patients and get embroiled in a discussion that they can't easily finish. So for the next few minutes, what I want to present is really some of the evidence out of the Surgeon General's report, just to show you the robustness of the evidence in support of the linkage between smoking and overall mortality and survival in cancer patients, and cancer-specific mortality, the response to treatment, how it's impacted by smoking, how toxicity is influenced by smoking, that's the toxicity of treatment, and the effects of smoking in terms of cancer recurrence and the risk of second primaries. To summarize at a high level what the Surgeon General's report says is that in both cancer patients and survivors of cancer treatment, the evidence that exists now is sufficient to infer a causal relationship between cigarette smoking and increased all-cause mortality, so death from all types of diseases, but as well cancer-specific mortality. As well, there's evidence that there's a causal relationship between smoking and an increased risk for second primary cancers, particularly lung cancer. And although the evidence is a little less robust and not really sufficient to infer a causal relationship, these other items on the screen now, there still is a fairly good amount of evidence to suggest that there is an increased risk of recurrence for certain types of cancer when the patient continues to smoke. There is evidence to suggest that in some cancers and with some drugs there's a poorer response to treatment. And there's certainly evidence to show increased toxicity as it relates to radiotherapy and surgery. So we're going to review that evidence now, starting with the evidence as it relates to overall survival after a cancer diagnosis. And the Surgeon General's report summarizes 62 cohort studies. 77% of them showed that continued cigarette smoking was associated with a shorter survival after diagnosis, and fully 42% of them were statistically significant. And in those studies, a small number where relative risk was reported, the median survival was less for former smokers by approximately 20%, and in those who were current smokers, 30% less when compared to never smokers. And there appeared to be a statistically significant trend in terms of worse survival by 1% for each additional pack year of smoking. And we know fully that smoking increases mortality from a variety of non-cancer related diseases like vascular disease, heart disease, cerebral vascular disease, and COPD. And smoking cessation reduces risk from these diseases, and sometimes very quickly, as in the case of risk of heart disease. So it's not surprising that all-cause mortality would be reduced in the cancer patient who stops smoking. And sometimes I'm asked, well, is that important if I'm an oncologist working in a cancer center? I'm not showing the data from one study in prostate cancer of several thousand patients, where the risk of dying from heart disease was about 10 times greater than the risk of dying from prostate cancer when treated with brachytherapy. So if you want the best outcome from your patient, you have to think beyond just the cancer and think about all-cause mortality. And that's a very powerful reason for treating them or introducing smoking cessation, particularly when the disease is potentially curable. But there's good evidence, and there's 58 studies on cancer-specific mortality, 79% of them having a higher cancer-specific mortality rate in the smokers compared with the non-smokers, and the majority of these studies were statistically significant, and again there was a dose-response relationship when looked for in 3 of these studies. One of the really interesting studies, and dramatically shows this, is one from Canada through the National Cancer Institute of Canada and published in the New England Journal in 1993 by Dr. George Broman, who evaluated patients who had head and neck cancer undergoing radical radiotherapy and evaluated whether they were smokers, recently quitters, or non-smokers. And there was a significantly different rate of complete response in those receiving radiation treatment, and you see the difference in percentage, 74% in the non-smokers versus 45% in those continuing to smoke. But look at the 2-year survival difference for the non-smokers, 66% versus 39% in those who continue to smoke during radiotherapy. And interestingly, recent quitters were more similar to the long-term quitters than to the people who had never smoked. And this is shown nicely on this panel of survival curves. The Kaplan-Meier survival curves show, first of all, on the left-hand panel, those who didn't smoke at all had the best survival, and those who smoked, obviously worse. On the right-hand panel, you see the intermediate survival of the recent quitters, which lends strength to the argument that even in the person you're looking at to start radiation treatment on in the clinic who's smoking, that getting them to stop then may improve their survival from that of a continuing smoker to that of a recent quitter, which looks more like the long-term quitters. There's also quite a bit of evidence about increased toxicity with cancer treatment. 82 studies in the Surgeon General's report, almost 100% of them showing a positive association between smoking and increased toxicity. Vast majority of them were statistically significant. As it relates to surgery, there's good evidence that quitting smoking decreases both local wound infections and other infections, as well as reducing the number of wound healing complications like wound dehiscence and hernias. And as it relates to radiotherapy, whether it's to the head and neck or to the abdomen or other body parts, radiotherapy administered while the patient continues to smoke does increase the toxicity and the risk of hospitalization from complications of the radiation in people who continue to smoke. And there are 51 studies in the literature on cigarette smoking and tumor recurrence. A vast majority of them are either statistically significant or have a 1.2-fold or greater relative risk increase. So again, one looks to see that continuing smoking while under treatment for cancer has the risk of increasing recurrence, and additionally the risk of second primary cancers, which is well recognized by oncologists because of the strong association of second malignancies in the smokers. Most typically that is a second primary, that is a lung cancer. And the risk of developing a lung cancer as a second primary is elevated at least 6 to maybe 24-fold in smokers relative to never smokers. So important reasons to encourage smoking cessation in patients receiving radiation or surgery. But here's some interesting thought-provoking information related to smoking and the receipt of chemotherapy. We recognize that cigarette smoke can have many impacts on drugs. Cigarette smoke in particular will increase the metabolism of drugs like theophylline by inducing hepatic enzymes. But the nicotine can also inhibit the apoptotic potential of drugs like cisplatin and others, and it can induce tumor cell proliferation and angiogenesis. And some of this is believed to be mediated through the N-acetylcholine receptors and the beta-adrenergic receptors, which affecting the cancerous tissue really promotes a more aggressive tumor phenotype that's less responsive to cancer treatment. This just shows the N-acetylcholine receptor and a particular subunit type that was thought to be most affected by nicotine, and how it can drive some of these well-known pathways within tumor cells that can result in increased tumor proliferation, or enhance the survival, or increase the angiogenesis that supports the growth of tumors. And there is evidence for several drugs now that, in fact, the plasma levels of these drugs is altered in the smoker as distinct from the non-smoker. And the first drug is irinotecan, commonly used in the management of colorectal cancer. And as shown here, the difference in the levels of or the amount in the plasma concentration times curve, so area under the curve amounts in smokers, very low versus non-smokers. And you might ask, well, is that important biologically or clinically? Well, the evidence is that the amount of treatment-induced neutropenia, the lowering of the blood counts in response to getting this cytotoxic drug, occurs quite infrequently in smokers, whereas it occurs in 30% of the non-smokers, a significant result. And a very similar sort of observation with erlotinib, EGFR inhibitor, and a much lower response rate in smokers versus never smokers. And you see the difference in the numbers, it's statistically significant. And some evidence that it would take twice the normal dose of erlotinib to achieve the circulating levels of that drug in the smokers versus the non-smokers. But this next slide shows a really very interesting study that was recently published. It's an international multi-center retrospective study, so it's not got the robustness of a randomized controlled clinical trial. Most of the patients came from Israel, but there's a number of American patients from Johns Hopkins Cancer Center. And what they did was undertake a multivariate analysis to determine the association between outcome and pretreatment smoking status, as well as some other prognostic factors. So they had patients with metastatic renal cell cancer, 278 of them, 59 were active smokers, and then some other risk factors, as you see. And it turned out that active smoking, compared to non-smokers, resulted in much less response, 54% versus 88%. But here's the real powerful message, that in the patients who were actively smoking, there was a significantly lower progression-free survival by 7 months, a difference of 4 months in the smokers with the metastatic renal cell cancer versus 11 months, and a lowering of the overall survival by 15 months. So a difference between 11 months in the smokers versus 26 months in the non-smokers. This is a very tantalizing bit of information, and if it stands up in randomized trials, will really be a very strong reason for getting our patients receiving cytotoxic drugs and molecular targeted therapies, and perhaps biologic therapies to stop smoking. This just shows the survival curves, the Kaplan-Meier curves from that publication, showing the very wide separation between the past and never smokers versus the active smokers. Very dramatic suggestion of benefit. So you would think that it would be then useful in randomized trials to collect information about smoking status. But unfortunately, we haven't been doing this. And as you can see, most clinical trials have no assessment at all of tobacco use, whether it's current or recent, and various types of smoking exposure. And this needs to change so that we can have a greater understanding of the impact of smoking on outcomes in patients receiving systemic therapies. So what we need in our province, and probably in many other jurisdictions, is a change in attitude, a change in culture, in fact, within our cancer treatment facilities, to turn them from institutions that focus exclusively on treatment of the cancer to a more holistic approach that focuses on how to get the best possible outcomes for their patients, which includes an improvement in all cause mortality, as well as cancer-specific mortality, reduction of toxicity, and reduced risk of recurrence and of second primaries. The reality is that although a lot of oncologists and others feel that cancer patients, when they receive a diagnosis, may not want to quit, there actually is strong evidence that most tobacco users want to quit. We rarely give them the help in our cancer treatment system to do so. And so we really need a change in attitude, and we need supportive policies, and certainly in hospitals in Ontario, which have gone smoke-free, then at least people undergoing cancer surgery and in-hospital treatments will, in essence, be forced to stop smoking. But in our ambulatory setting, we really need to focus there to help our smokers quit so that they can get the best possible results from their treatment. And we have to recognize that health professionals do have the trust of their patients, and hence health professionals, be they specialist oncologists or primary care providers or nurses or radiation therapists, have a prominent role in tobacco control to help achieve the best outcomes for cancer patients. So at this point, I'm going to pass over to Rebecca Truscott, who's going to give you an overview of the Cancer Care Ontario smoking cessation interventions that we're undertaking through our regional cancer programs.
Thank you, Bill. So what I'll do is go through the background and history of the program, talk about what the program looks like and the current state that it's in right now. We'll have an overview of some of the data that we've recently got in from the regional cancer programs, and then I'll go through some of the highlights and talk about the future plans for the program. At Cancer Care Ontario, or CCO as we like to call it, we've had a focus on cancer risk reduction, as it was called out as a priority in our Ontario Cancer Plan back in 2011, where regional cancer centres were targeted to be models in cancer risk reduction. And we have had this smoking cessation initiative under this priority. For 3 fiscal years, actually, from 2012-13 to the current year, 2014-15, we've been able to focus the dollars that we have for cancer prevention in the regional cancer centers to focus exclusively on smoking cessation activities, which has really helped to get the program going. Historically, what has happened here in Ontario is that back in 2011, CCO pulled together a steering committee to really focus on what an approach could look like within the regional cancer centers. So the membership included experts in smoking cessation from across the province and representatives from all of our regional cancer programs, both clinical and administrative experts. So it was really helpful to have both of those pieces involved. We also had partner groups involved in this steering committee from the Canadian Cancer Society, Smokers Helpline, CAMH, the Ottawa Heart Institute, and also the Ministry of Health and Long-Term Care here in Ontario. This group had about a 6-month time period to pull together a framework with some recommendations about how we could address smoking cessation within the cancer centers. This framework was developed and then approved and endorsed by our CCO leadership back in September of 2012. The vision for our initiative is that we are offering smoking cessation intervention to every ambulatory cancer patient. So we're screening everyone that comes into the centers in order to ensure that cancer patients in Ontario achieve the best possible health outcomes from their cancer treatments. And we really want the focus to be on optimizing the cancer treatments that patients are going through based on the evidence that Dr. Evans just presented to you. The program that we have is really tried to be integrated into the cancer care that's happening and right into the clinical flow within the cancer centers. So we do have a primary focus on ambulatory cancer patients, and we're using an adapted 5A's approach that's well accepted within the tobacco control field. You can see here from our delivery model, the 3 boxes at the top that are red, these are really left to regional adaptation and implementation. So training and the decision on how intensive the intervention is at each of the regional cancer centers is determined regionally. The counseling service can be offered either within the center or through a partner organization within the region. In the blue box, we have our ask. So all ambulatory cancer patients are being screened. They're asked whether or not they are currently using tobacco or if they've had any tobacco, even a puff of a cigarette, within the past 6 months. Then they're all advised on the benefits of quitting and how it would help their cancer treatment to quit smoking. The assess and assist are sometimes coupled together and sometimes actually omitted, and the clinician will progress straight to the arrange, depending on the services that are available within the center, to refer to someone for further cessation advice. You can see in the perforated boxes, we have some ideas for future expansion of the program. So we would like to create a link back to primary care providers, formally have that link. There are some centers that are providing a letter to primary care physicians to let them know that their cancer patients have been counseled in smoking cessation, but this isn't occurring systematically across the province yet. We'd also like to eventually capture the follow-up in terms of the referrals, if they actually were followed up on, and whether or not any quit attempts were made and the success of that quit attempt. We're also looking to expand in the future to other populations, be it family members living with a cancer patient or other well populations like our breast screening program population. This is the structure of our program. So we're very fortunate to have kept on a number of the individuals that were part of our original steering committee to be part of our Smoking Cessation Advisory Committee. Dr. Evans continues to be the chair of this work, and the group meets about 4 to 6 times a year to really provide guidance and strategic advice to how to strengthen and improve the program. We have 14 regional smoking cessation champions designated at each of our regional cancer programs, and these individuals are really instrumental in ensuring that the implementation happens across the province, and they're responsible for the implementation within their regional cancer centers. We do have a minimum data set that we collect data on regularly. So on a monthly basis, we receive data to be able to calculate these performance indicators. So those that are screened for tobacco over the number of new ambulatory care cases that come into the cancer centers, the prevalence of smokers or tobacco users among those screened, those that are advised on the benefits of cessation over the current or recent tobacco users. And then we're also looking at those that are recommended of referral. So what's the proportion of cancer patients that are being recommended for cessation referrals? And we're also interested in whether or not that referral is in-house within the cancer center or with an external partner within the community. Excuse me. So here's a look at some of data from our cancer centers from earlier this year. So from about April 1st till the end of September, that's Q1 and Q2 for us. You can see that about 55% of the cancer patients, ambulatory cancer patients, are currently being screened for their smoking status. We've got a prevalence of recent tobacco users at around 25%. And of those that are current smokers, where we are advising between 70 and 80, so 80%, so probably around 75% on the benefits of quitting smoking. And of those that are being advised, a referral for further cessation support is being recommended to over 40% of the population. And about 70% are accepting that referral for further support. You can see that there is actually an equal breakdown of how these referrals for further counseling are happening. So about 40% are happening internal within the Regional Cancer Centre, and about 40% are being referred on to external services. And there's a good 20% of patients that are being offered both an internal referral and an external referral. So it could be that there's an in-house quit specialist within the cancer center who sees a client and then refers them on to follow up through Smokers Helpline. That is a model that a number of the centers are using. So now just to speak to some of the highlights of our work over the past couple years, we've really been able to train regionally more than 1,000 providers just in one fiscal year, so we're very excited about that. We're very, very pleased that now all 14 of our regional cancer programs are reporting data into CCO on a monthly basis, and this is a huge, huge accomplishment for us. So at this time last year, when we would have first received data from the RCCs, there were only 5 regions that were able to report the data to us on those performance metrics. So we're very pleased now that we can get data in from all 14 of them. As I mentioned, we have designated champions for each of the regional cancer programs, and we meet monthly with them over the phone and over the internet to facilitate information sharing, joint problem solving, networking, and to really support each other in the work that's happening across the province. We also have had in-person meetings with this group on a yearly basis, and these have also been very instrumental in keeping the momentum going and seeing that all of our champions remain motivated to do this work. We also saw a gap in patient education materials available at the cancer centers, and worked with a working group of our champions to develop a patient resource that addresses smoking cessation exclusively for those that are part of the cancer patient population. So we're working with Smokers Helpline to get that laid out and finalized for the end of this month or early next month. We're also really fortunate that our provincial leadership and executive leadership at Cancer Care Ontario is committed to smoking cessation for cancer patients, and we're continuing to see an interest in it from that leadership table, which is excellent. We have ongoing guidance through our advisory committee. We're very fortunate to receive that, and we are looking forward to the Ontario Cancer Plan 4, which will be coming out next week, as it will also speak to smoking cessation and tobacco control within the regional cancer centers. Very soon we will have access to the data that we've gathered through the evaluation of our pilot. So after 1 year of receiving data from the cancer centers, we're having a look back to see what we can improve, and we'll be able to share that report in the coming months. And then we're also really fortunate and excited to start thinking about the potential expansion of our program to other populations. I mentioned earlier the breast screening program and family members of patients. We're also exploring how we could incorporate it into the diagnostic assessment programs and the surgical oncology network. And at this time, I'd like to ask if there are any questions on the line. Thank you.
So what we'll do at this point is both our presenters will be able to answer a few questions, and I'll guide that question and answer period. We actually have a first question from Brent, and Brent is asking, can you discuss how you collect your minimal data set?
Well, the indicators were developed through our steering committee, and then finalized with our advisory group. So that's how we determine what those minimum indicators would be. And the data that comes into us at Cancer Care Ontario, what we've done is tried to piggyback on an existing data collection tool within Cancer Care Ontario. So now this regular reporting is part of the data that the cancer centers have to submit to us on a monthly basis. It's part of that package.
Brent may be asking more specifically how it's collected at the front line in the cancer center. Does the oncologist ask the questions about smoking or not? Is the nurse? Is it the receptionist at the desk? And I don't know the exact answer, but I think all of those are options, and different centers are implementing the way they've found will work best for them.
Okay. We have another question coming from Judy. Have you developed a clinical practice guideline for smoking cessation in oncology?
To my knowledge at the moment, there's no practice guideline from our initiative at Cancer Care Ontario. We rely on the program and evidence-based care to generate guidance for diagnosis, treatment, follow-up, and so on, and a number of screening guidelines. But to this date, we have not yet created one for smoking cessation. But I note that the NCCN has recently come out with guidelines in the last few days, in fact. So various organizations are, in fact, actively working to produce guidelines. And in the absence of one from Cancer Care Ontario, I could direct you to the recent publication of a guideline from the NCCN.
Mm-hmm.
Okay, we have Jennifer asking, how did you provide the education to your practitioners? And perhaps we can elaborate on how extensive was it?
Well, one aspect of the education has actually been to take this particular presentation enriched considerably because of just time constraints today, with more data from the U.S. Surgeon General's report and other sources to all of the regional cancer centers, and to present at rounds and to encourage the practitioners to realize that this has got to be part of their work. Part of it is helping the oncologists do this in the most efficient way, because the big pushback that I have heard as I've made these presentations in some of our cancer centers is that they're too busy, there's so much work, there's so much complexity to the management of the cancer patients today that they just really don't want to take on one more thing. So what we've been doing, as well as convincing them that there is this body of evidence that there are true health benefits to their patients, and this is really a quality of care issue. And if they want to do their best for the patients, they have to participate. But what they can do can be very brief but very powerful, and that is simply to tell their patient that the best thing the patient can do for themselves is to quit smoking, and they will direct them to an individual or resources that will help them. The oncologist is most likely not going to be the primary agent for smoking cessation. They simply don't have the time to counsel the patients. They may not have the expertise to prescribe pharmacotherapy. They may not even want to get into that. But if they can simply make a statement that it's important and they want the patient to stop, and refer them to the nurse who will talk to them more about the resources available, then perhaps to Smokers Helpline or to Public Health or to smoking cessation counselor right in the cancer center, whatever the resources are that are available. The physician, if they do that, is going to be very helpful and impactful in getting the patient to make that decision to quit.
Thanks, Dr. Evans. We have another question from, or perhaps a statement even, from Jez Bindra, who's saying, in public health, we are promoting the youcanmakeithappen.ca website. Just wondering if this information on the importance of cancer patients quitting smoking is on that site. So perhaps if you're familiar with that, if you can touch base on that, or...
I'm personally not familiar with it, but now that you've raised it, a good place to go and visit and see what information is there, because it'd be great if there's a consistency of information. I must say, and I sort of addressed it partially in my talk, a lot of this information on health benefits to cancer patients has only recently kind of been pulled together through the American Association for Cancer Research, the Institute of Medicine, and the Surgeon General's report. But it is gaining momentum, and the International Association for the Study of Lung Cancer has done a webinar on this. Our Canadian Partnership Against Cancer is pulling people together to address this across our country. So you can sort of feel the momentum building. So it's important that all of the information resources that are out there speak to this issue, and that the evidence for health benefits in cancer be made more aware to the public at large, to primary care, as I emphasized in my talk, and not just to the specialist in the cancer system.
Okay, so I'll just ask you to come over a little bit for this while we're having you off screen. All right, perfect. So taking the next question from Temi, have you considered addressing the other modifiable risk factors in a cancer care setting?
I do know that at Cancer Care Ontario, they're currently working not on our side of things, but looking at integrating physical activity into treatment for cancer patients. So I think that work is being done. It's not part of the work that we're involved in.
But you raise a good point. There are other modifiable risk factors, be they your diet and exercise, as Rebecca has said. I must say, in all of these instances, I think you have the same resistance factor. Both, it's hard to change human behavior, number one, and the other thing is that cancer centers are very busy places, and it's hard then to get those who are involved in cancer treatment to recommend some of these other risk reduction strategies. There's quite powerful evidence as it relates to exercise in cancer that outcomes are improved by exercise programs. And we have mounted such programs in the center I used to be responsible for, but the uptake is small, largely because oncologists have not endorsed them and don't have it top of mind to recommend to their patients. They're seemingly too focused on the actual specific cancer treatment that they're offering. And I think this is something we have to gradually overcome and think more holistically if patients are to get the best benefits overall. But thank you for that point.
Okay, we have a few more questions from Karen. What standard screening tool do you use, and is it the same across all cancer programs in Ontario?
We did circulate to our champions a standard screening script that would have the language that they can use and adapt according to the clinician's preference. And it is modeled after the Ottawa model script, but it is not being used across the province. So there are some centers that use their own screening tool. We've recently implemented data calls with each of our centers to really find out more about how the data is flowing and how it's being captured. And we have noticed a couple of issues that we need to tighten up. And that is one of them. And I think that this has really resulted from the way in which our program evolved. So when our program came together in 2012, there were a number of cancer centers that were already quite far down the road in terms of the program that they were offering their cancer patients. So probably, a handful, between 3 and 5 that had a program already established. For the rest of the centers, it was something that they needed to develop and needed a lot more coaching and guiding, and we needed to be cognizant of the leaders that were already are performing well and capturing the data that we wanted them to capture, but just using a slightly modified script.
Thank you, Rebecca. We actually have, I guess, a success story that's being shared by Miriam, and Miriam's sharing that at Cancer Care Manitoba, they are actually already implementing a similar assessment program and helping patients in the oncology setting. And for those who aren't familiar, we have featured Cancer Care Manitoba's success story in a previous webinar. So if you are interested in hearing more about that, be sure to check out the Teach Project website for an archived webinar with some of that information. A following question from Jennifer. She says, you mentioned nicotine affecting treatment. Do you use NRT in the centers?
You know, the short answer, Jennifer, is yes. This comes up commonly because um, uh, two things are active here. First of all, there's a cigarette smoke, which may be components thereof are affecting some of those hepatic enzyme and maybe changing metabolism, whereas the nicotine may be impacting some of the cellular responses to drugs like cisplatin and changing the tumor phenotype. So naturally, there's some worry about nicotine in that context, but there is no evidence at the present time that giving NRT negatively impacts the results of treatment. And I think that when you're giving NRT, first of all, it's in sustained slow release. In most cases, if you're using a patch or some other delivery mode, and it's not achieving the same concentrations and height of levels in the bloodstream as cigarette smoke. It's also avoiding all the toxicity of cigarette smoke. So I think that although I prefer in many respects that nicotine not be in the patient's system when they're receiving anti-cancer therapy, I think when it's part of getting them off of it over a period of weeks, that it's still one of the most effective ways of treating the addicted cigarette smoker.
All right, so we have a few questions. I can see Natalie and Monica are asking similar questions with regards to barriers. So Natalie is wondering, within CCO, are there any barriers to implementing the tobacco cessation in cancer care programs, and how have you overcome them? And along the same lines, we have Monica wondering, how do you overcome resistance from healthcare practitioners?
Well, I'll start, and maybe Rebecca can add to this. I think that as I've given these talks in cancer centers, the most common barriers are, first of all, a lack of awareness about the health benefits. So it's kind of the ignorance of the literature that's out there, which you can overcome. But the more difficult thing to overcome is the fact that oncologists feel sometimes quite overwhelmed with the amount of work they have to undertake in seeing patients and managing them through complex care and so on. And they see this as just one more thing. It's kind of the straw that's breaking their back. And so it's very important in terms of overcoming that barrier to give them a simple solution so that it's not seen as an onerous task. And I say to them, it takes 10 seconds or less to reinforce the message that cessation is important to get the best outcomes from their treatment. And frankly, I can't imagine a cancer patient, when told that by a specialist oncologist, who would want to keep smoking, because every cancer patient would like to get the best outcomes, I'm sure, in terms of survival and least toxicity. And if that message is coupled with, and I'm going to refer you to, and then to resources that are there in that cancer center. But that does lead to the next barrier. I think ideally, those resources should be in the cancer center and easily accessible. After all, these patients are often coming multiple times a month for the radiation, for their chemotherapy treatments, etc. So to have them go somewhere else is a bit challenging. And it would be good if you could hand off right in the cancer center to someone that they can have a face-to-face conversation with, at least initially, about smoking cessation, and begin a counseling and maybe do the prescription of the NRT and or other pharmacotherapy. But that costs money. So there's a need for more resources in our cancer centers so that that's enabled. There are, of course, a lot of community resources, and so our programs are making a lot of use of them, but it would probably be somewhat more effective if at least there was contact by a smoking cessation counselor right in the cancer center, and that will, as I say, cost us more money, which we're, through our Ontario Cancer Plan, hoping to receive in due course from the Ministry of Health. Anything to add, Rebecca?
I think some of the more logistical challenges have been related to the documentation practices. So we do hear anecdotally that the clinicians are advising, they're screening for smoking, they're advising their patients to quit smoking, but it's not being documented, or it's being documented on a paper survey, which then needs to be entered into a computer in order for the data to get to CCO. So the challenges there are numerous. There's also challenges with different technology platforms and having them talk to each other within the cancer center. Sometimes there's up to 4 or 5 different systems that the clinicians need to enter the data into, and then it needs to be all pulled together. And the challenge is really trying to make the folks that are in charge of the technology side of things see that it's a priority to make those changes, so that to facilitate the data capture. And really, I think that in the way that we've been able to really overcome that is try to get the message out to the executive leadership at the hospitals about the importance of this intervention. And I think until you get that senior level buy-in, it's very challenging to make an intervention like this work.
Okay, it looks like we have time for one last question. So we'll take a question from Mark, who is asking, does NRT also activate the CYC enzymes?
Mark, to the best of my knowledge, and I'm not an expert in the biologic features, but I'm told that it's really the tobacco smoke that is what's responsible for, and the components thereof, but not the NRT per se, or nicotine that's activating the CYP3 and other cytochrome enzymes that change metabolism of drugs and so on. So I think it's that's not the issue with the NRT. So that's my knowledge of it. I hope I'm accurate on it.
Okay, thank you so much. So we're just about wrapping up, and we would like to thank both our presenters, Dr. Bill Evans and Rebecca, for joining us today. It was a wonderful and very informative presentation, and we hope that as the topic continues to grow in interest and importance, that we are able to see more implementation into practice in the cancer care settings. As a reminder, a link to the post-webinar learning assessment and evaluation will be sent by email, and you have 1 week to complete this learning assessment in order to complete your in order to receive your letter of completion. And if you did join us today by participating as a group, make sure to email Parazad Hathadaro at the email found on the screen by the end of today. Again, we thank you very much for joining, and we hope you have a wonderful rest of the afternoon.